I'm a licensed clinical therapist at Tennessee Valley Mental Health Institute in Nashville, Tennessee. Or at least I was until I submitted my resignation last month. You can call me Dr. Laura Bennett if you want, though most people in the practice just called me Dr. Bennett during my 15 years there. I've seen everything you can imagine in clinical psychology: severe depression, bipolar disorder, schizophrenia, PTSD, dissociative identity disorder, and every kind of trauma the human mind can endure. But what I'm about to tell you about is the one case that made me question everything I thought I knew about consciousness, memory, and the nature of human identity, and ultimately led me to leave the profession entirely. Tennessee Valley Mental Health Institute is a comprehensive psychiatric facility serving the greater Nashville metropolitan area and surrounding counties. It's a modern complex built in the early 2000s with specialized units for inpatient care, outpatient therapy, and residential treatment programs. The facility handles approximately 12,000 patients annually across all services. During my time there, I specialized in trauma therapy and dissociative disorders, working primarily with patients who had experienced severe childhood abuse, combat trauma, and complex psychological conditions that required intensive, long-term treatment. The case I'm about to tell you about began on a humid Thursday afternoon in March 2023. It was the kind of Tennessee spring day where the air felt heavy and electric, and storm clouds gathered over the Cumberland River in the distance. I had been seeing patients since 8 a.m., and by 3 p.m., I was looking forward to my last appointment of the day and the weekend ahead. My 3 p.m. slot was supposed to be a new patient intake, someone referred by Dr. Daniel Foster from the Emergency Psychiatric Services at Vanderbilt University Medical Center. The referral notes were unusually sparse. Adult female, approximately 28 years old, found wandering downtown Nashville 3 days earlier with no identification and no memory of how she had gotten there. She had been cleared medically at Vanderbilt, with no signs of drug or alcohol use, no head trauma, and no evidence of physical abuse or assault. The preliminary diagnosis was dissociative amnesia, possibly related to a traumatic event, though no specific trauma had been identified. The patient had been cooperative during her evaluation at Vanderbilt University Medical Center, but she claimed to have no memory of her identity, her past, or any events prior to being found by Metro Nashville police officers near the Shelby Street Bridge. At 3:05 p.m., my receptionist, Janet Miller, knocked on my office door. "Dr. Bennett, your 3 o'clock appointment is here, but there's something you should know. She doesn't have any paperwork with her, no insurance cards, no identification. The hospital sent over her medical records, but that's all we have." "Did she fill out our standard intake forms?" I asked. "She tried, but she left most of it blank. Name, address, emergency contact, medical history, everything. She said she can't remember any of it." I had worked with dissociative amnesia cases before, though they were relatively rare in clinical practice. Most cases of memory loss had clear organic causes, head injuries, strokes, or degenerative diseases. Psychological amnesia, where memories were suppressed or blocked due to trauma, was much less common and often temporary. I walked to the waiting room to meet my new patient, and immediately noticed something unusual about her appearance. She was sitting perfectly still in one of our standard waiting room chairs, hands folded in her lap, staring straight ahead with an expression of complete calm. Most new patients, especially those dealing with memory loss or trauma, showed some signs of anxiety, confusion, or distress. This woman looked like she was meditating. She appeared to be in her late 20s, with dark brown hair pulled back in a simple ponytail, wearing plain jeans and a gray sweater that looked new and expensive, though they had no visible brand labels or tags. Her posture was unusually erect, almost military in its precision, and when she turned to look at me, her eye contact was direct and unwavering. "Hello, I'm Dr. Bennett," I said, extending my hand. "You must be." "I don't know," she replied simply, shaking my hand with a firm, confident grip. "That's why I'm here, I suppose." Her voice was clear and articulate, with what sounded like a slight accent I couldn't place. There was no tremor, no hesitation, none of the uncertainty I would expect from someone experiencing severe memory loss. We walked back to my office, and I noticed that she moved with unusual purpose and awareness, taking in details of the hallway, the other office doors, and the layout of the building in a way that seemed methodical rather than curious. "Please, have a seat wherever you're comfortable," I said, gesturing to the seating options in my office. I always let new patients choose where to sit as a way of giving them some control over their environment and helping them feel more at ease. She chose the chair directly facing my desk, sat down with perfect posture, and waited for me to begin the session. No fidgeting, no nervous glances around the room, no questions about the process or what to expect. It was as if she had done this many times before. "I'd like to start by asking you to tell me about the last thing you remember clearly," I said, pulling out my intake forms and clinical notepad. "I remember waking up on a bench near the river 3 days ago. It was early morning, maybe 6 o'clock or 6:30, based on the light. I was wearing these clothes, though I have no memory of putting them on. I had no identification, no belongings, no sense of how I had gotten there." "What did you do when you realized you couldn't remember anything?" "I sat on the bench for approximately 2 hours, trying to access any memories from before that morning. When nothing came, I began walking through the city to see if anything looked familiar. Eventually, I approached a police officer and explained my situation. Her description was remarkably detailed and organized for someone supposedly experiencing severe amnesia. She spoke about her experience with the kind of clinical detachment I might use when describing a case to a colleague. "How are you feeling about not being able to remember your past?" I asked. "I find it interesting rather than distressing," she said. "Most people seem to expect that I should be upset or frightened by the memory loss, but I don't feel that way. It's more like a puzzle to be solved than a tragedy to be endured." That response was the first thing that struck me as genuinely unusual. Patients with dissociative amnesia typically experienced significant emotional distress about their memory loss. The inability to remember one's identity, relationships, or personal history was profoundly disorienting and frightening for most people. This patient's calm acceptance of her situation was inconsistent with everything I knew about trauma-related memory disorders. "Have you had any flashes of memory, dreams, or moments when something seemed familiar since you were found?" I asked. "No specific memories, but I seem to have retained certain skills and knowledge. I know how to read and write. I can perform mathematical calculations. I understand complex concepts and vocabulary. I seem to be fluent in at least 3 languages, English, Spanish, and what I think might be French, though I have no memory of learning them. Which languages feel most natural to you?" She paused for a moment, as if considering something carefully. "That's an interesting question. All 3 feel equally natural, as if I learned them simultaneously rather than sequentially. But there are moments when I feel like there might be other languages as well. Words or phrases that seem familiar but that I can't quite access." I spent the next hour conducting a standard psychological assessment, testing her cognitive function, memory capacity, and emotional state. Her performance was remarkable. Her IQ appeared to be well above average, her vocabulary was extensive and sophisticated, and her reasoning abilities were excellent. She could perform complex mental calculations, recall and analyze detailed information I provided during our session, and demonstrate problem-solving skills that suggested advanced education or training. But when I asked about autobiographical memories, family relationships, childhood experiences, or personal preferences, she had no access to any of that information. "Do you have any sense of what you might have done for work?" I asked. Based on my apparent skills and knowledge base, I would guess something that required analytical thinking, attention to detail, and the ability to process complex information quickly. Perhaps something in research, analysis, or assessment of some kind. "What about personal preferences? Foods you like or dislike, types of music, hobbies?" I don't seem to have strong preferences about anything. When the hospital staff asked me what I wanted to eat, I told them anything would be fine, and I meant it. I seemed to be equally comfortable with any type of food, music, or activity. This was another significant red flag. Even patients with severe amnesia typically retained some emotional responses to different stimuli. They might not remember why they preferred classical music to jazz, but the emotional response would still be there. This patient showed no preferential responses to anything. As our session continued, I began to notice subtle inconsistencies in her presentation that didn't align with any recognized memory disorder. She claimed to have no memory of her past, but her behavior suggested extensive experience with psychiatric evaluation and therapy. She anticipated my questions, positioned herself in the chair in a way that suggested familiarity with clinical settings, and used therapeutic language with precision that indicated previous exposure to mental health treatment. "Have you ever been in therapy before?" I asked directly. "I don't remember being in therapy, but I seem to understand the process and vocabulary associated with psychological treatment. What do you understand about why you're here?" "You're trying to determine whether my memory loss is organic, meaning caused by a physical problem with my brain, or psychological, meaning caused by trauma or stress that my mind is trying to protect me from by blocking access to certain memories." That was a textbook explanation of dissociative amnesia that would typically take several sessions to communicate to a patient. She understood complex psychological concepts with a depth that suggested professional training or extensive personal experience with mental health treatment. I decided to try a different approach. "I'm going to say some words, and I want you to tell me the first thing that comes to mind, even if it doesn't make sense to you." Childhood: nothing. Mother: nothing. Father: nothing. Home: nothing. Hospital. She paused for the first time since the session began. Assessment. What kind of assessment? I'm not sure. The word assessment feels significant, but I can't access why. School. Training. What kind of training? I don't know, but it was extensive and intensive. I continued with the word association exercise, and a pattern began to emerge. She had no response to words related to personal relationships, emotions, or family connections. But she showed immediate recognition of words related to evaluation, analysis, testing, and professional or academic settings. "Let me ask you something different," I said. "If I told you that I thought you were lying about your memory loss, how would that make you feel?" For the first time since I met her, her perfectly composed expression changed slightly. It wasn't anger or defensiveness, which would be normal responses to such an accusation. It was something closer to curiosity or intellectual interest. "That would be a reasonable hypothesis to consider," she said. "What evidence led you to that conclusion?" It was the response of someone trained in analytical thinking, not the response of a traumatized patient being accused of deception. After that first session, I was convinced that this case was far more complex than a straightforward dissociative amnesia diagnosis. I scheduled follow-up appointments twice a week and began conducting more specialized assessments to try to understand what was really happening with this patient. Over the next 3 weeks, I administered every psychological test and evaluation tool available in our facility. The results were consistent and puzzling. Her cognitive abilities were exceptional across all domains. Her emotional responses were remarkably flat and controlled. Her knowledge base seemed to include advanced understanding of psychology, neuroscience, research methodology, and data analysis. Most significantly, she showed no signs of trauma response, no hypervigilance, no startle responses, no anxiety or depression, no sleep disturbances or nightmares. Patients with trauma-induced amnesia typically showed clear signs of underlying psychological distress, even if they couldn't remember the specific events that caused their condition. This patient displayed no psychological distress at all. During our 4th session, I decided to confront her directly about my observations. "I want to share something with you," I said. "In 15 years of clinical practice, I've never seen a presentation quite like yours. Your memory loss is complete and consistent, but you show none of the emotional or psychological symptoms that typically accompany dissociative amnesia." "What do you think that means?" she asked. "I think you know exactly who you are and why you're here." She looked at me for a long moment with those same calm, analytical eyes. "That's an interesting conclusion. What would you like to know?" "I'd like to know your real name, how you ended up on that bench, and why you're presenting as an amnesia patient when you clearly don't have amnesia." "Those are very reasonable questions, Dr. Bennett. But I think the more important question is whether you're prepared for answers that might challenge your understanding of how memory, identity, and consciousness actually work." The way she said it sent a chill down my spine. It wasn't a threat, but it was a warning. "I'm a psychologist," I said. "I've been trained to handle complex and challenging cases. Whatever your situation is, I'm prepared to help you work through it." She leaned back in her chair and, for the first time since I'd met her, smiled. It wasn't a warm or reassuring smile. It was the kind of smile that suggested she knew something I didn't, something significant. "Dr. Bennett, what if I told you that everything you understand about human memory and identity is fundamentally limited? What if I told you that the concepts of individual consciousness and permanent identity that form the basis of your therapeutic approach are more flexible than you realize?" I'd say that sounds like an interesting philosophical discussion, but it doesn't answer my questions about who you are and why you're here. "Fair enough. My name, at least the one I've been using most recently, is Dr. Rebecca Sloan. I have a doctorate in experimental psychology from Stanford University with specialized training in memory research and consciousness studies. I work for a research institute that studies unusual neurological and psychological phenomena." "What kind of research institute?" "The kind that investigates cases that don't fit into conventional medical or psychological categories. The kind that studies people who experience things that challenge our current understanding of how the human mind works." "And why were you found with no identification, presenting as an amnesia patient?" "Because I volunteered to undergo an experimental procedure that temporarily suppresses autobiographical memories while leaving cognitive and procedural memories intact. The goal was to see if it would be possible for trained observers to detect the difference between genuine trauma-induced amnesia and artificially induced memory suppression." I felt like the ground had shifted underneath me. "You're telling me that your memory loss was artificially induced, as part of some kind of experiment?" "That's correct. And you, Dr. Bennett, along with the staff at OHSU and everyone else who evaluated me, were unknowing participants in a study of diagnostic accuracy in cases of unusual memory presentation. That's completely unethical. You can't conduct research on people without their informed consent." "You're absolutely right, which is why the study has been terminated, and I'm here to provide you with full disclosure about what happened." Over the next 2 hours, Rebecca, if that was really her name, explained a story that was even more disturbing than I had imagined. According to her account, she worked for a private research institute called the Institute for Consciousness Studies, funded by a combination of government agencies and private technology companies. The institute investigated unusual cases of memory, consciousness, and identity that couldn't be explained by conventional neuroscience or psychology. "We study people who claim to remember past lives, individuals who seem to share memories with family members they've never met, cases where patients demonstrate knowledge or skills they shouldn't have access to, and situations where consciousness appears to persist in ways that defy current scientific understanding." "That sounds like pseudoscience," I said. "I understand your skepticism. 5 years ago, I would have agreed with you, but I've seen cases that can't be explained by any conventional model of how memory and consciousness work." She described her own case as a test of an experimental technique that could temporarily block access to autobiographical memories without affecting other cognitive functions. The goal was to create a controlled amnesia that would be indistinguishable from trauma-induced memory loss. The procedure involves a combination of pharmaceutical intervention and targeted electromagnetic stimulation of specific brain regions. It's designed to temporarily disrupt the neural pathways that connect personal memories to conscious awareness while leaving language, skills, and intellectual abilities intact. And you volunteered to undergo this procedure? I did. The research team wanted to see if mental health professionals could distinguish between genuine dissociative amnesia and artificially induced memory suppression. Your diagnostic accuracy and the treatment approaches you used were part of the data we were collecting. How many other therapists were unknowingly involved in this study? Across the country, approximately 40 mental health professionals evaluated similar cases over the past 2 years. The goal was to develop better diagnostic criteria for genuine dissociative disorders and to understand the limitations of current assessment methods. I was horrified by the ethical implications of what she was describing. This is a massive violation of professional ethics and research protocols. Mental health professionals can't be used as unwitting research subjects. You're correct, which is why the study has been discontinued and all participants are being debriefed about their involvement. So your memories are returning now? I asked. The effects of the procedure began wearing off about a week ago. I've been gradually regaining access to my autobiographical memories, though the process has been unusual. Unusual how? The memories aren't returning in chronological order, and some of them feel different than they did before the procedure. It's as if the artificial amnesia changed not just my ability to access memories, but the quality of the memories themselves. What do you mean by that? Rebecca was quiet for several minutes, and for the first time since I'd known her, she looked genuinely troubled. Dr. Bennett, I need to tell you something that's going to sound impossible, but I need you to listen carefully and try to keep an open mind. I'm listening. When my memories started returning, I discovered that some of them don't belong to me. I have clear, detailed recollections of events that I never experienced, conversations I never had, places I've never been. But they feel as real and authentic as my actual memories. That could be a side effect of the experimental procedure. Artificial memories or confabulations are a known risk with any intervention that affects memory formation or retrieval. That's what I thought initially, but these aren't random false memories. They're coherent, consistent, and they involve people who actually exist. I've been able to verify some of the events and conversations by contacting the people involved. What do you mean you've verified them? I mean, I called my colleague, Dr. Kevin Marshall at the University of Washington, and asked him about a conversation I remembered having with him in his office last month. He confirmed that the conversation happened exactly as I remembered it. The problem is, I've never been to the University of Washington. I've never met Dr. Marshall in person, and according to my actual memories, I was in California during the time when that conversation supposedly took place. I felt a familiar chill of unease. There has to be a rational explanation for that. I've found 12 separate instances where I have detailed memories of events that I can verify actually happened, but that I couldn't have experienced myself. Some of them involve people I've never met, in locations I've never visited, during time periods when I can account for my actual whereabouts. Rebecca reached into her purse and pulled out a notebook filled with detailed notes and documentation. I've been systematically investigating these impossible memories, and I've discovered a pattern that I can't explain. She showed me pages of carefully organized information, dates, locations, names, phone numbers, and detailed descriptions of events and conversations. All of these impossible memories involve other researchers who work in consciousness studies, memory research, or related fields. It's as if the experimental procedure somehow gave me access to memories from other people who are working on similar research. That's scientifically impossible. Memories are encoded in individual brains through specific neural pathways. There's no mechanism by which one person could access another person's memories. I know that, but I also know that I have detailed recollections of a conference presentation given by Dr. Rachel Morgan at the University of Tennessee Health Science Center in Memphis last year, including specific questions from the audience and Dr. Morgan's responses. When I contacted Dr. Morgan, she confirmed that everything I remembered was accurate down to the smallest details. Rebecca showed me transcripts of phone conversations she had recorded with various researchers, all confirming that her impossible memories were accurate accounts of real events. Dr. Bennett, I need you to understand that I'm not delusional or confabulating. I'm a trained researcher who has spent the past month systematically documenting and verifying these experiences. I have access to memories that I shouldn't be able to access, and I don't understand how or why. Let's assume for a moment that what you're telling me is true, I said. What do you think it means? I think it means that our understanding of how consciousness and memory work is fundamentally incomplete. If the experimental procedure somehow disrupted the normal boundaries that separate individual minds, then everything we think we know about personal identity and individual consciousness needs to be reconsidered. Or it means that the experimental procedure caused severe psychological side effects that are creating elaborate delusions. That's possible too, but if these are delusions, they're remarkably consistent and verifiable delusions. And there's something else. Rebecca hesitated, and I could see that whatever she was about to tell me was something she found deeply disturbing. I'm not the only one experiencing this. I've made contact with 3 other research subjects who underwent similar experimental procedures at different institutions over the past year. All of them are reporting access to impossible memories, and there's overlap in the experiences we're describing. What kind of overlap? 2 of the other subjects have memories of conversations and events that I also remember, even though none of us were physically present at those events. It's as if we're accessing the same set of external memories from multiple perspectives. The implications of what she was suggesting were staggering. If multiple people were accessing the same impossible memories, it suggested either a coordinated delusional system or something far more disturbing about the nature of human consciousness. Rebecca, I need to ask you something directly. Do you believe that you're experiencing some kind of supernatural or paranormal phenomenon? No, I don't think this is supernatural. I think it's natural, but it's operating through mechanisms that we don't understand yet. Just like radio waves were natural phenomena before we understood electromagnetic radiation. What do you think is really happening? I think consciousness might not be as individual and isolated as we assume. I think there might be ways that minds can connect or share information that we haven't discovered yet. And I think the experimental procedure accidentally tapped into whatever those mechanisms are. And what do you want from me? I want your help documenting and understanding what's happening to me and the other research subjects. I want to approach this systematically and scientifically, and I need a mental health professional who can help assess whether we're experiencing genuine anomalous phenomena or complex psychological side effects. I spent the next several weeks working with Rebecca to document her experiences and investigate her claims. What I found was deeply unsettling. Her impossible memories were remarkably detailed, consistent, and verifiable. She could describe conversations, research findings, and even personal details about researchers she claimed never to have met. When I contacted some of these people myself, they confirmed the accuracy of information that Rebecca shouldn't have been able to access. More disturbing was the discovery that the other research subjects she had mentioned were reporting similar experiences, and their accounts overlapped in ways that suggested they were accessing information from a shared source rather than generating independent delusions. After 2 months of investigation, I reached a conclusion that I never thought I would reach as a trained psychologist. Rebecca and the other research subjects were experiencing something that our current understanding of consciousness and memory could not adequately explain. They weren't delusional. They weren't confabulating. They weren't experiencing psychological side effects from experimental procedures. They were accessing information and memories that they shouldn't have been able to access through mechanisms that we don't understand. The implications were profound and terrifying. If consciousness could somehow transcend individual brains, if memories could be shared or accessed across separate minds, then everything we thought we knew about personal identity, individual responsibility, and the nature of human experience needed to be reconsidered. I tried to continue working with Rebecca and the other research subjects, but I found myself increasingly unable to function as a therapist. How could I help people understand their individual psychological experiences if individual consciousness might not be as individual as I had always believed? 3 months after Rebecca first walked into my office, I submitted my resignation from Tennessee Valley Mental Health Institute. In my resignation letter, I cited personal reasons for leaving, but the truth was that her case had fundamentally undermined my confidence in everything I thought I knew about the human mind. I moved to a small town in rural East Tennessee where I now work as a school counselor, dealing with academic problems, social issues, and other straightforward challenges that don't require me to confront the nature of consciousness or the boundaries of individual identity. But I still think about Rebecca's case every day. I wonder what happened to her and the other research subjects. I wonder if there are more people out there experiencing similar phenomena. And I wonder if the scientific and medical communities will ever be ready to acknowledge that our understanding of human consciousness is more limited than we realize. Most of all, I wonder if Rebecca was right when she said that consciousness might not be as individual and isolated as we assume. Because if she was right, then every therapeutic relationship I ever had, every individual treatment plan I ever developed, and every assumption I ever made about personal identity and individual experience might have been based on a fundamental misunderstanding of how human minds actually work. The case of Rebecca Sloan will always remain for me the most unexplained and disturbing experience of my career as a therapist. It taught me that the boundaries between individual minds might be more fluid than we realize, and that the nature of human consciousness contains mysteries that we are only beginning to acknowledge. I sleep better now in my small town, but I still lock my doors twice before bed, because somewhere out there might be other people walking around with access to memories that don't belong to them, and I'm not sure any of us are prepared for what that really means about the nature of human identity and individual consciousness.